Yeah.
I'm Dr. Turk. I teach chemistry here at Alma College, and it's my pleasure to introduce everybody here to today's event. So this is a part of what we call the Your Health lecture series, and it comes about by a partnership of Alma College, Saginaw Valley State University, Michigan State University College of Human Medicine, and MyMichigan Health. And it's this partnership to bring together physicians and researchers to give talks to the public. And so we not only have some academicians here, some students and such, we also invite the public as well to attend. So this is an annual talk that happens here, and they travel around the state of Michigan. This is our time. So welcome everybody, thank you. I'm going to introduce Mark Grieve. He's the Director of Community and Government Relations with Michigan State University's College of Human Medicine. He's going to introduce our keynote speaker.
All right. Thank you, Dr. Turk, and thank you for those that joined in person and those joining virtual via Zoom. And as Dr. Turk said, my name is Mark Grieve, Director of Community and Government Relations at Michigan State University College of Human Medicine. MSU College of Human Medicine and Alma College have been collaborating on the Your Health Lecture Series for at least the past 10 years as an extension of the Early Assurance Program agreement between our two schools. And I want to thank Dr. Turk and Alma College for that continued partnership. I would like to note that at the conclusion of Dr. Valles' presentation, he will answer questions from the audience, and then also we'll do our best to try to grab written questions in the Q&A via the Zoom Q&A function as well. With that, I would like to introduce our speaker this evening. Dr. Sean Valles is Director and Associate Professor in the Michigan State University Center for Bioethics and Social Justice. Dr. Valles is a philosopher of health, specializing in the ethical and evidentiary complexities of how social contexts, everything from one's local food options to the presence or absence of exposure to violent policing practices, combine to create patterns of inequitable health disparities. His work includes studying the challenges of responsibly using race and ethnicity concepts in monitoring health disparities, scrutinizing the rhetoric of the COVID-19 pandemic as an unprecedented problem that could not be prepared for, and examining how biomedicine meshes with public health and population health. He is author of the 2018 book, Philosophy of Population Health, Philosophy for a New Public Health Era, and he is also co-editor of the Oxford University Press book series, Bioethics of Social Justice. Dr. Valles.
Thank you very much. I really appreciate the opportunity to be here. This is, let me know, by the way, if you can't hear me in the back. Masks and much tech, and so it's complicated. So I thank you for this partnership that allows me to be here. I am fairly new to the College of Human Medicine. I only started in 2021. I'm old to MSU, I guess, since I started in 2010, and I moved from other colleges into College of Human Medicine. So anyway, I'll jump right into it, but this is really fun. So thanks for this. So normally I would start with a slide showing the title, but I think it's more fun to have something interactive. And so maybe you didn't use your camera to point at that thing, and take a look at, which you don't have to take a look at the map that pops up. I find this fun. I don't know. I have a different sense of fun than a lot of other people do. And so what it is a map of life expectancies from some hyper local data that was collected shortly before the pandemic started. So this is pre-pandemic data about life expectancy in individual what's called census tracts, the way the US Census sort of divides up into sort of like quasi neighborhoods. And you can see that they are quite different. And here is me cross-referencing the ones in the Alma area with countries that have the same life expectancy. This isn't to make fun of any neighborhoods, nor to make fun of any countries, but it's a way of sort of thinking about, on the theme of today, sort of thinking about zip code and genetic code and what matters more. This is sort of how far apart we live from our neighbors. in one sense. And so while we might live right next to, if you live in this neighborhood and you're right over here, or you're right here and your neighbor's over there, well, you are geographically right next to each other, but in some sense you're worlds apart because your life expectancies are 6.8 years apart. And this is not unusual, not across the US. When I was growing up in the Boston area, outside of like right outside of Boston, and when I was in high school, I lived other places as well. I didn't realize when I was there, because I think partially some of the data hadn't even been collected yet. If I went 2 blocks away, there was sort of like a very different feel to the neighborhood. What I didn't know is that the life expectancy dropped by 10.6 years if I went 2 blocks away. And so that is the scale of differences that we're facing when we're sort of thinking about like zip codes and how different are things. Like 10.6 years different, that's a lot. If I went across town to go visit my girlfriend's house, I would go through another neighborhood where people lived on average 93 years, on average. And so like, you know, that's not the same as there. So this is what I find to be interesting, because this isn't a map of genetics. Like this isn't a map of behaviors, not really. And so like, what is this a map of? And so like, what is making it like this? And that's what I study. And so like, how did we get here and what do we do about this kind of stuff? So there's this, it's sort of hit the mainstream to a certain extent. This sort of like, it's kind of like a motto at this point, that your zip code matters more than your genetic code. It's really pithy. And I think it sort of bears some scrutiny. So it's like, well, is it true that your zip code matters more than your genetic code? Or is it false? Is it misleading? I think it largely holds up, but it's complicated. And so, so it's showing up inside news reports and inside journal articles and inside press releases from Harvard Medical School. It just showed up last year inside a White House press briefing. I can't say that word. And so it's like on the White House website. It's like it's being transmitted from the White House. And so this is stuff that's like really hit the mainstream. This idea that your zip code matters more than your genetic code. And you can look at the same sort of effects at other scales. By the way, there's nothing special about zip codes. Those are just sort of arbitrary units. But you can look at the same thing from the lens of micro neighborhoods. You can look at it based on households. You can do it based on countries. And so this is just comparing the vast differences between individual countries. What happened what happened to their life expectancies during the first year of the pandemic? That's the only 2020 we actually have like sort of solid data on by this point. Where pretty soon we'll get 2021 data in to see like how bad it went. Early data says like bad. And so on one end of the spectrum, you have New Zealand, where they actually lived longer in 2020 than they did in 2019. Like they were actually doing better than usual. And same with Taiwan and South Korea. On the other end, you have Russia and the United States that both lost roughly a couple of years of life. It was much worse for some populations. So Hispanic men like me lost an average of 3.7 years. That's a lot. There are things I'd like to accomplish in 3.7 years. So, so again, like you can sort of do this at different geographical scales. And so in response to things like those kinds of disparities, one of the sort of the proposals out there is that we need to start thinking about a culture of health. We need to start, and so you've probably heard the term at this point, maybe not. So the National Academy of Medicine is starting to write about this stuff. The Robert Wood Johnson Foundation is pushing really hard on this inside their health funding. They're a major health agency or private health foundation. The state of Michigan is giving out awards to individual employers that are promoting a culture of health inside their workplaces, and so you can get like a culture of health award by the state of Michigan. And so this is hitting the mainstream. This is a textbook that some colleagues of mine wrote. And so so it's again, there's this like other sort of like phrase that people are sort of kicking around, and again, the question is like, does this make sense? Is this a thing that we should be going for? Is this how we should be talking about this kind of stuff? And again, I'm going to say yes, but again, it is complicated. So the reason that a lot of this stuff interests me is it all sort of meshes together under this idea of population health. And I happened to write a book about it. And so I wrote a book about what is population health, essentially, and why I think it sort of makes sense as a way of thinking about health. And I will briefly say, what exactly is it? Well, It is as defined by some people who are sort of some chief popularizers of it. It's a research program that confronts the structural forces, so think about features of society, that place individuals at risk, that creates distributions of health and disease unequally across socially defined groups. So think about the different experiences of those zip codes, those different neighborhoods on the maps, and focuses on embedding biological pathways, so biology matters, within social interactions that develop across the life course. And so what's happening to you from birth through death. And so the accumulated things, exposure to pollution, stuff like that, and across generations. And so it's sort of a hot area now to look at intergenerational effects. And so if you undergo some sort of health trauma prior to conception, does that sort of show up inside the next generation? So what kinds of effects, whether even just epigenetic effects that sort of like attach to your that literally attach to your DNA, or whether it's something that like a cultural practice that sort of gets handed down at the same time as that sort of thing. And so things change across generations. And it sort of started getting sort of like formulated as a discrete way of thinking about health in the early to mid 90s. This is a volume that came out for the Canadian Institute for Advanced Research, and it sort of created the field and asked the question: why are some people, think populations, why are some peoples healthy and others not? And that became the sort of central question. So like, why are some populations, why are some zip codes healthy and others not? So when you're trying to understand like, okay, so zip code matters, something's happening inside geography. One of the sort of the intuitive things that people have been trying to do is to try to like break it down and like, okay, this zip code is doing worse than this other zip code. What exactly is contributing to it? How much of it is like because of the physical environment? Is it because of lead exposure, like welcome to Michigan? Is it because of some kind of employment thing? Is it because of education levels? Like what exactly is going on? So they try to sort of parse it and they say, okay, maybe it's like a big pie chart. And this slice of it is because of their environmental exposures, and this slice of it is because of their behaviors. And so they're breathing some bad air, and some of their foods are not super nutritious. And so like, they all sort of add up to this one thing. And it's a nice idea, but it kind of doesn't really work that way. And it's really frustrating because we want to have sort of neat pockets where we can say this much of our problem is because of lack of access to hospitals, and this much of the problem is because of exposure to lead. But unfortunately, there's been roughly 100, 150, you could say a couple thousand, sort of depends on how you measure it, years worth of debates over how to sort of think about this. And so there have been fights since the dawn of genetics about how do we think about the interactions between genes and environments. And so you have the genetic biological components, and you have the environmental exposures. And so how do we sort of think about the ways that those relate to each other? And so in genetics, you have G cross E discussions. And so how do you think about interactive effects, and how do you need to worry about those? How do you even sort of conceptualize some of them? And inside biology and medicine, you have these effects where you think about how do we sort of parse apart the individual, their genetics, their behaviors, and their health outcomes. And so if you think about something like myopia, so like a lot of people in this room, like most rooms, have myopia. And so the question is, how do we sort of think about that, about the prevalence of that kind of condition? And so some of it's genetic, and we know some of the genetic factors that go into it. We know it's a lot of them, and we can pinpoint some of them. But it sort of depends on how you think about it. So some people come into it thinking, okay, what are the factors that lead to myopia from those genetic factors? Other people come into it thinking, what are the factors that go into having a hard time being able to see? Because it's not the same thing. Because in one sense, you can solve the problem of myopia by giving people access to glasses. And so then the problem of myopia isn't that much of a problem as long as you're wearing glasses. And so different populations might have the same prevalence of myopia, but they won't have the same prevalence of having a hard time seeing. And so like, do you have glasses or not? But then it gets more complicated, because no matter what your genetics of myopia are, if you're exposed to a cultural system in which you have high intensity studying based on reading books and computer screens, that vastly increases rates of myopia. And so it's not just your genetics, but it's also what you're exposed to over the course of your lifetime. And so if you're exposed to this expectation that you do a lot of straining your eyes, then you have more myopia. And so how do we sort of parse those apart? So like how much of myopia in this problem is because of genetics, how much of it is because of environment, and how much of it is because of individual behaviors? Like it's kind of hard to say how this works. And so if you're interested in the history of this, my friend Jim Tabery wrote a book about this, thinking about nature versus nurture and genes versus environment and that kind of thing. It goes back, I could bore you with some of the history of biology because that's part of my background research. But basically this is something that's been happening for a long time, and this is very much political stuff at the same time. Because if you approach the myopia as a genetic issue, that's very different than thinking about it as a problem of making sure that we give children glasses if they need them for school, or changing the educational system so the kids aren't straining their eyes. Those are very different ways of thinking about the same kind of problem. And so there's some real basically proxy wars is the way they end up being, and sort of how we think about this stuff. And so it's very political, whether we like it or not. And so, an important population health theorist pointed this out in a recent article, saying, well, you just can't think of these things as if they sort of add up to 100%. And so myopia or whatever other kind of problem, it's not 30% genetic and 40% environmental or something like that, and 20% cultural or something. It doesn't work that way. It's not a pie chart. It'd be nice if it were pie charts, but it just isn't. And even Hippocrates of the Hippocratic Oath fame was pointing this stuff out a couple thousand years ago. So when he was writing 2,400 years ago, he was saying that if you want to understand a population, you move to a new area and you want to treat the people there. First, you have to understand what kind of world they live in. And so you go in and you look around, and is it the kind of place where people's sort of daily behavior means they get a lot of exercise? Well, that matters. Do they drink a lot? What do they drink? Is their water contaminated? What's it contaminated with? And so if you want to understand what all those things are, so you have to understand their environment, and then you have to understand how their environment shapes their behaviors. So if they're winemakers, then that's their behavior that's partially influenced by the fact that they live in wine country. If it's a fishing village, then they fish, and so that's going to influence what they eat. And so he thought behavior is basically just environmental. And so to him, it was like you have to understand population behaviors, but behaviors is part of their environment to him. And so you can even take some of these things and you can sort of reclassify them. We think of behavior as being sort of separate from the environment, but to him, it was sort of the other way around. And it really depends on how you look at it. And so again, we can't sort of think of these things as being modules. So there have been attempts to try to give other models for it, and they kind of don't make any sense to look at. And so this is Krieger saying, it doesn't add up to 100%. I'm like, yes, totally it doesn't. And she's like, it works like this. I'm like, okay, sure, I can't teach this because it's like gender inequity and racial and ethnic inequities. Like, yes, totally, and it happens over the life course from in utero through adulthood, and it matters at the household level and the regional level and the national level. Like true. Like I wish this were made any sense to look at. Like this is no pie charts, and it's I've looked at I think pretty much every attempt to try to give a diagram for this, and it never works. Or at least they might work, but it's kind of hard to make any sense of. So we're drawn to the neatness of thinking about all we have to do is to just make sure we understand this part of myopia. We just need to solve this one piece, and if only. So genetic codes, zip codes, they both matter, but they matter to different things. Sorry, I was checking time. So we're about 20 minutes in, right? Something like that, yeah. So one way of thinking about this is a proposal that was put out by the epidemiologist and also physician Jeffrey Rose. And he said that what we need to understand is that there's a difference between what he calls the causes of cases and the causes of incidents. And so one question is, what's going on with this patient? Why did they get sick? What is making them do this? This patient who has diabetes, not every patient has diabetes. What's up with this person? Is it something that is because of their diet? Is because they inherited some sort of genes? What's going on here? And often the answer is going to include a lot of genetics. And so if I get diabetes and I have a family history of diabetes, and I do, then that's going to then, like, obviously genetics and family history is kind of like a proxy for genetics in a lot of ways. Then, like, obviously that's gonna be part of the answer. So like a huge part of that's gonna be that. Or if I get heart disease, okay, true. That's very different from asking, why is this zip code, this population, why does it have so much, why does so many people there have diabetes and that zip code right over there doesn't? They share the same hospital. They even shop at sometimes the same grocery store. What's going on? Why is that one different from that one? And these are just two very different questions. And so when people try to actually investigate this empirically, there's a really cool paper from 2015 by Kaufman et al. And they look at the massive amount of research that's been collected on all of the known genetic factors that relate to heart disease risk. And it's basically, if you know any genomics, it's not too difficult to pick out the signals. You can basically sort of look for signals of any kind of relevance between individual sort of genetic regions, and that might have some sort of association with any kind of health outcome. So genome-wide association studies. And so it's pretty easy to find the signals. It's hard to decode them, but to know like roughly where they are. And then also looking at what are the known differences between Black American populations and white American populations. There aren't a whole lot of genetic ones. And if you want to say, okay, people have been hypothesizing, it must be something about being Black that makes you at higher risk for heart disease. And so they looked at it and so, okay, like let's test that. Is there any association between the small but real genetic differences on average between these two populations? No, none of that matches up at all with any kind of heart disease risk. And so what's going on there? Something environmental. It's something else that's going on. And so there is a massive literature on what happens when you don't have lower average income, systematic exclusion from all sorts of occupations, discrimination in housing, discrimination in healthcare, your doctor not believing you when you say that you're sick, being underprescribed medications, like we know a lot of things that are going on. And so what we have at the same time is there's a huge difference in morbidity and mortality between sickness and death rates for heart disease among Black Americans and white Americans, but they have nothing to do with genetics. And so if you want to understand individual genetics, this patient, we should understand, yes, that's going to help us understand what's going on with them. But it's not going to tell you anything about the disparity between Black Americans and white Americans. And you can do the same kind of research on Hispanic Americans and rates of diabetes. And so my population has higher rates of diabetes than average, but that's not because of our genetics either. And so you can do the same kind of thing again and again. And so these things are both true. So something could be hugely important for understanding individual health and do nothing to understand population differences. So this is the problem that we're faced with, is that sometimes they'll line up and sometimes they're 100% apart. Which means that sometimes we have to make choices. And so Rose, when he's looking at this, he's saying, okay, what I'm taking away from this, and this is the way he starts his book, is, as far as I know, this is sort of a statement of empirical fact that, as it was known at the time, it's held up pretty well over time. And it's also an ethical provocation. He's saying, I can see that this person who has a genetic disease or was born with a heart defect or whatever, they had to get sick in some sense, at least until we can do something about genetics. That's gene therapy or whatever. But for this population, this zip code, no zip code has to be sicker than another zip code, ever. It doesn't have to be that way. That's a political choice. It's a social choice. It is a thing that is optional. And that was like really throwing down the gauntlet that like there never has to be a sicker population than another one. But I think it's basically right that we're going to differ from each other for genetic reasons, but as long as our genetic reasons don't really match up, our genetic differences don't match up with our sort of social worlds that we create, as long as our zip codes aren't genetic differences, and they largely aren't, then why would we have sick zip codes? It doesn't have to be that way. Like the neighborhood next to mine people didn't have to live 10.6 years shorter than my population did. And the people across town didn't have to live another 9 years. It just didn't have to be that way. But that just raises all kinds of questions now, doesn't it? But in the meantime, this means that the reason a patient is sick is not the same reasons that a population is sick, but both need attention. These both matter. And I bring it up now during this auspicious pandemic because we have not really been putting a whole lot of attention into sick populations. And so I will, for the next, maybe forever, I will point out that shortly before the pandemic started, in the cover issue of in May 2019 of the American Journal of Public Health, they were worried very deeply about the public health workforce threatened by mass extinction. Yeah, that was a choice. And then this also, and again, population health and individual health are not separate problems because we are also doing a really crappy job, according to this February 2019 issue, saying, wow, we should really worry about the health of healthcare workers. We have not been giving a lot of attention to that. This could really come back to bite us in the ass. It kind of did. Like, thank you, healthcare workers. Like, it's been a rough couple of years. And so, like, who cares about the health of the healthcare workers? Well, I don't think they knew how that was going to play out in like April 2020. It got weird. So one way of understanding the problem here is that not that we have to sort of make a choice between like, oh, we need to think about only individual health matters, only population health matters. I think it's a false choice. We don't have to choose one or the other. Again, these things are connected to each other, just like worrying about the population health of individual carers. These are not separate issues, but I think it's important to recognize that, at least in the United States, we're kind of obsessed with dealing with our population problems as individual problems. It's kind of like a defining, I'd say maybe it's kind of a defining characteristic about the way we sort of think about the world. And so if you look at healthcare expenditures or health expenditures, we spend about 2.5 cents of every dollar on public health and the rest on individual health. That's not me saying like we need to give less money to Medicare. It's me saying like maybe we should spend more than 2.5 cents. I'm not complaining about the 97.5 cents. I'm worried about the 2.5, especially since if you actually like look more closely at the data, it's actually closer to like 1.5 cents because they sort of like double count certain stuff. And so that's not a lot of money going to our population problems, not when they're as big as the stuff in the map I just showed, or whatever you looked at. I don't even know like what you looked at. I intuitively sort of looked at my house and like, so like how long do people live where I live? Like, oh, interesting. Oh, that explains a lot. And so if you want to put in Rose's distinction between sick individuals and sick populations, we spend a lot of our money on sick individuals, and we're in the process, we're neglecting sick populations. And you can't deal with all of our collective problems through individual solutions. You might have noticed this during the pandemic, that like trying to deal with this is like a series of like, okay, the problem is that we have 300 million people that are making bad food choices. Like that does not make a whole lot of sense for like trying to think about like sort of culture-wide problems. And this, I'm starting to lead towards like, so why are we thinking about a culture of health? So I don't want to sort of belabor this point, especially for time purposes, but if you look at how we're handling this in the United States, this is comparing how much individual countries spend over time on health versus how long they live. Again, I'll say this all the time, life expectancy isn't the only thing that matters, but like all things being equal, I want to be not dead. So in 1970, we're spending less than $2,000. This is adjusted for inflation. Less than $2,000 per person. We're only living a little over 70 years on average, and it's gone up a little bit since then, but it hasn't gone very high. But what we have done is gone really far to this side, and so we're spending a ton of money per person, and what it's not buying us is more elevation. Other countries are doing much better, so they're going up and to the right. And so Switzerland spends more than most other countries, except for the United States, but at least they're getting something out of it. And France is doing better, but they're spending less. And Chile and Portugal are doing much better, and they're spending like a tiny fraction of that. And so so that's just like one of the many ways of thinking like maybe we can sort of individual spend our way out of our population problems. So we have to deal with population health problems like this one. This is a lot of the research on population health was really sort of strongly influenced by research sort of identifying what's called the wealth health gradient and sort of thinking basically how deep the problem goes. It started with some research in the UK, but then it sort of spread throughout the world. And so other countries have a version of this kind of graph. Ours is unusual internationally because of how steep it is. And so for every percentile of income that your household makes, you get an appreciable difference in how long you live. And this sort of like, the reason I present this kind of thing is if you go into the clinic and you're talking to a patient, because I talk to a lot of medical students or or physicians, and I'm being in College of Human Medicine. If you walk into a clinic and your patient is sick and you know that part of the problem is their diet, for instance, if you approach them thinking like, okay, why aren't you eating better? Why aren't you doing a better job with this? Aren't you exercising? Like, you can sort of think about this as like, what did you do wrong? At least that's the way that patients receive a lot of those kinds of interactions. But then I look at a graph like this, is like thinking about this, like, oh, what did you do so well? Like, you must be a very virtuous person. No, like, you must have made some terrible life choices. That's why you're living that's why you're not living very long. Like, no, like, this isn't like a graph of like virtue or like making good choices. This is a graph of wealth. And so it just happens to be the case that like upper middle income people live substantially longer than lower middle income people. This is a life expectancy at 40, by the way. I think about this every year when I either do or don't get a raise. Yeah, you're laughing, but like, think it through. It's like, why do you need a raise? Like, because I want to not die. Like, I'm sorry, I didn't make the rules. And unfortunately, we are not doing a great job with this. And so this does map on to other things. It's not as if wealth is randomly distributed in the population. You might have noticed this before, if you were ever anywhere. And so we have problems like massive wealth disparities. And so not just income, but also how much money do you have? And so it is still roughly the same. I think it's actually gotten worse during the pandemic. The data is still coming out. But roughly the average Latino family has 10 times less wealth than roughly 10 times less wealth than white families. It's a problem. Yeah, that's just really messed up. This also holds even for if you control for income, and so even middle income Black, and I think also Hispanic families, there's a vast disparity in how much wealth they have. And so you might have an income, but if you haven't had many generations to build up wealth or access to things like being able to build up equity through housing because you've been redlined out of neighborhoods, as has happened for hundreds of years, then that's a problem. So the idea is, in response to this, well, we need a culture of health. And so we need to basically change everything, is the idea. The more modest version that's been pushed, especially by the World Health Organization, is that we need action across society. And so every part of society needs to be working towards the goal of better health. And so we need businesses that are thinking about the health of their workers. We need urban design to be built around the idea of thinking that, well, is this going to be a healthy place to live? Are there places where children can play safely? Are there places to exercise that are accessible? If someone wants to walk somewhere or bike somewhere instead of driving, can they do that? And so these kinds of things should be sort of on the agenda for everyone. It doesn't have to be the only thing we think about, but it should be on the table every time. And so they started saying this with this proposal that we need to be thinking mainly about trying to promote health in areas outside of healthcare. Healthcare is already doing a perfectly good job of thinking about health. And so what about everyone else? Like, what are we doing in our tax system so that we can try to make people be able to deal with things like that wealth disparity gap? And so, like, can we do anything to sort of like change some of those rates of people dying younger and because they are poor? Eventually started turning into a proposal called Health in All Policies. This is sort of like an overall framework where it's a confusing set of terminology because it's a description and also a suggestion. And so it is saying that whether you like it or not, educational policy is health policy because people who are highly educated live much longer and they have much better health throughout their lives on average. And it's also an ethical imperative that like people, you need to be thinking about health in all your policies. If you think about debt relief in colleges without thinking about health, you're going to be missing a lot of the point. You're going to be missing a lot of repercussions, either for good or for bad. And we need to think, not only do we need to think about this as a matter of sort of general health, we also need to think about it as a matter of equity. And so we need to think about the justice aspects of this. This is something that's been pushed by the American Public Health Association. Like, we need to think about this as a matter of equity and creating a just world. And so most of you probably heard of the social determinants of health. This is sort of just like one way of thinking about it. It's a sort of somewhat limited approach, but what the social determinants of health research that's out there, if you're familiar with any of it, is it sort of points how deep the problem goes. So it's not just that we need action across societies. It's not just that it's a broad problem, it's a very deep problem as well. And so I have a separate talk I can sort of say more about it in discussion, but like this report points out that incarceration and mass incarceration is a problem for health. There's a huge growing literature on basically showing that in communities where there are high rates of incarceration are suffering, even if you're not incarcerated, it disrupts families. And so where did the caregiver go? Where did the child care go? Where did the earnings go? And all these kinds of things are sort of are really adding up for communities, and it's reducing overall population health, not just for the people who go to prison. That it really sucks to go to prison also. And so thinking about sort of how deep some of these problems go, like, well, if our incarceration system and our criminal justice system are contributing to poor health, like, wow, that means we have to have a whole criminal justice reform conversation, and it also should be partially a health conversation. Like, that's a lot. Like, that's really deep stuff, and it's going to be opening new questions and old questions at the same time. It's going to be really hard, but the point is, like, whether you like it or not, criminal justice policies are health policies, like health in all policies. Like, sorry guys, like that's just the way it is. And so it's, well, again, broad reform and also deep reform. Like, again, if we want to do better, like that is an if, because not doing better, well, you saw the graph, like that's kind of been our thing. I know I'm being flippant, but like, yeah. So is the rhetoric appropriate in the sense that, like, do zip codes matter more than genetic codes? Well, to population health, they do. And so we just need to know what we're talking about. And so, like, in what way are they more important? So if you want to address population level issues, then yeah, zip codes do matter more than genetic codes. If you want to address disparities between populations. Although it's also true that they are interactive. And so zip codes and genetic codes are not mutually exclusive things. They have overlapping effects. They interact. This is something that's been sort of like kicked around again as a theoretical dispute for the last roughly 100 years, sort of more. And do we need a culture of health? Well, that does seem like what we need, but I think we need to be ready for it, because it means we're gonna have to sort of look at every corner of society to deal with it. And so this is sort of like my sort of main research program is saying that, like, we need to deal with health problems as everyday living problems, but like it's like all the stuff. And it also means we have to go real deep. And so these problems go really, really far down. And so we can't deal with them just by, oh, we're just going to try to reform our healthcare system. Like, yeah, we totally need to do that. Like, there are a lot of ways it could be a lot better, but that's not going to get rid of those disparities. If we had a perfectly well-functioning healthcare system, we would still have those disparities between zip codes. And we need to be able to acknowledge, yes, we should reform our healthcare system, totally, for lots of reasons, but that's not going to solve all our problems. And I feel like a lot of people were sort of disappointed that reforming our healthcare system, both didn't reform as much as we thought it might, but also even if it did do all the stuff it was supposed to do, it wasn't going to solve all our problems. And that's really annoying. But I unfortunately don't have any good news, or at least not a whole lot. So anyway, I'll just wrap up there. I have more slides and stuff I can show, but let's stop there, because it's already earlier there was a reference to trying to drink from a fire hose. Want to learn about health policies? Okay, wait, but hey, income, wealth, health disparities, racial disparities. Okay, it's too much. Let's take a break. Thank you.
So questions, we'll maybe start in the room, and then I'll see if I can.
Yeah, turn off the slides. I guess I can make reference to stuff.
Okay.
There. That's what's bright. It's nice.
Let's see. All right.
Yes.
This is such a big problem.
The
honestly
biggest.
everywhere.
Or something.
Yeah.
That's what I mean, just like it's
It's like everything.
Yeah.
So like what's your opinion on like where to start with attacking this problem, which could be different in like different places, but like how do you start to address this?
Can you, Sean, can you?
Oh, repeat the
it?
question. So the question was basically, given that this is such a massive problem, like where do we start? Because it seems like impossibly big. Maybe this is my bias as like a philosopher or something, that like the value of sort of like understanding. I do think there are real limits to like how much like awareness can bias. But I think we can't, let me put it this way. I think we can't make good headway if we think the problem is limited in scope. And so just sort of like acknowledging that like first you have to understand and acknowledge that you have a problem. And so there's a big National Academy of Medicine report on US health, and it was called US Health and International Perspective, with shorter lives and worse health, I think. And basically the summary of it was like which of these areas of the world are contributing to America's worse health compared to every other wealthy country? And so is it because of our economic system? Is it because of our healthcare system? Is it because of the way we design our neighborhoods? Is it because of this? And the answer was like, yes. But like, that's not as like annoying of an answer that is, that like, is that a problem? Like, yes, that's a problem. Like all of it. We can't fix it if we think it's just the healthcare system. Then it means that like every time we get sick, we blame our doctors, and that's unreasonable. I think we have like unreasonable expectations for lots of different people. And so if we think that like we can deal with our problems without putting a roof over people's heads and giving them enough food to eat at night, then like we're gonna like get really frustrated. Like, why isn't this working? It's like, well, because we're only dealing with part of it. And so like I think we need to have like a reckoning with like it's all broken. I'm sorry.
And those joining us online, if you want to
Thanks
put questions into Q&A, feel free to do so.
Do you think we're seeing lower expectancies in more urban or rural areas?
The question was, are we seeing worse life expectancies in urban versus rural areas? Different. It varies a bit by place. There was some recent research that was really pointing out like worries about the health trends, especially in rural areas. It would be a little too complicated to get into. We can talk later if you want, but just because it's sort of getting at some theoretical disputes about like what's going on. There was worries about what was basically coined as the idea that there are deaths of despair in certain parts of the country, especially rural areas, where there was sort of like a general sense of they attributed a lack of a sense that there is like a future for parts of the areas, that like relying on industries that weren't going to come back, and sort of worried about general trends and like not enough people live here, we can't, like this isn't working or something like that. That's been tied into claims about voting patterns and the rise of populism and stuff like that. So it's all like a big, very, very politicized area of research that's connected to a bunch of other areas of research. Right now, there's some interesting trend. So there are some worrisome trends in rural populations, especially. There are also a lot of areas of extremely concentrated poverty inside cities as well, and concentrated disadvantage. And so it's a bit of both. And so it doesn't map neatly. And so even if there were like an overall trend, I think that would sort of be flattening of the experiences of people inside cities and also people in rural areas, because they're just different from each other in a lot of ways, and sometimes for the better and sometimes for the worse. And something that also gets flattened by things like life expectancy. And so if you see that like on average, according to the data, again, this is like a really complicated thing, and it might be partially a statistical artifact, but Hispanic people tend to live relatively long compared to other populations in the United States, but we tend to have worse health in some areas. And so then it's a matter of like, well, life expectancy matters, but so does health and morbidity. And so you don't want to sort of like to flatten too much. And so I was giving like a big picture thing. I want to be like respectful of the fact that like it's just different.
So we do have a couple questions online, so we can kind of maybe go back and forth. But the first question I see is there anything an individual can do to improve things?
Vote. I'm being serious that there's a disheartening aspect of health in all policies where it's like, oh my God, it's like health in all policies. Like it's too much, it's too big, like as the point was before. The flip side of it is it's health in all policies, which means anything that I can do to sort of like push things in the right direction, you can move the needle in the right direction. And so if workplace health matters, and like, again, like Michigan's like giving like awards to like workplaces that have like healthier policies, then like push for things that you can control. And so things like maternity leave and paternity leave, we have some of the worst perinatal, so before, during, and after birth outcomes in the world, like always compared to other wealthy countries. And so like that doesn't have to be that way. We don't have to have mothers dying after giving childbirth. We have to have babies dying. That's ridiculous. And so like if we can do things like trying to get access to people so they can take time off if they need it. One thing that I try to advocate for is folks who need disability accommodations, and sometimes they're afraid to ask for it, or they're worried their employer won't provide them or something like that. Like we can sort of make a positive impact in a lot of different ways because everything matters. It means it's sort of both disheartening. Again, this is sort of like a shorthand, like everything matters, but if everything matters, then anything that you can do can help. And so you might only be able to do a little bit, but like, it means that whatever you can sort of do to sort of like push things in your local settings, whether you're working in a hospital or you're able to influence somebody and say like, hey, can we do this thing instead? Or can I have a different way of like getting a break so I can walk around or something, or so I don't have as much lower back pain? Like it's the little things that add up. And so if you can find any optimism in that, like, good for you. I sometimes can't, it depends on the day.
Question in the room? Otherwise, I can go online again. How do we address the relationship between lower income areas, stress, self-medicating like cigarette use, alcohol use, etc., and subsequent health issues?
Yeah, again, this is sort of going deep into some of the disputes about like sort of like what's the right way of going about this. I have personally advocated for what's called a fundamental causes approach, which is that we need to sort of first address certain types of causes that sort of keep popping up as problems again and again. And so poverty is one of them. And so it happens to be the case that it's hard to do anything if you don't have money. And so there is a very, very strong association between having money and being able to have good health outcomes. And the thing that's pointed out inside the empirical literature, especially from this sort of theoretical standpoint of fundamental causes, is that the way that money is helpful changes every year. And so your ability to have access to Zoom as opposed to going to work in person didn't matter that much in 2019 for most people, but it sure mattered in 2020, didn't it? That had a huge impact on your ability to live a healthy life. And so money is always going to be helpful. And so if we are going to recognize that like the lack of resources is going to be like a persistent problem so that people have a hard time living with whatever the problem of the day is, whether it's rising gas prices this week, or next week it could be rising food prices because of something else, like whatever the problem is, then we need to find a way of making sure that people aren't going to be basically like thrown to the winds of fate because they have lack of money. So there are some sort of very ambitious attempts to do things like try to have like universal basic income, which is like a big move to try to have basically like people have like a basic amount of money just to live. There are other attempts to try to deal with it in a more piecemeal manner, but like I think we need to recognize that there are certain patterns like racial privilege is another area that's been research saying that like this is a problem across contexts and over time, and same thing with discrimination of other kinds, and poverty is another one. Education level is another area where we need to give people access to education because that has such a strong association with health outcomes across different parts of the world and over time. And so if we don't get at some of the root problems, or what's sometimes called upstream problems, we're only going to be dealing with problems downstream and never actually going up to the source.
Any questions in the room? All right, I have a little bit of a lengthy one, but I think it's a good question. I recently moved from the Metro Detroit area to Port Huron. I see the health of people in Port Huron is not good. Transportation is a problem, addiction is a problem, and there are several programs for recovery. For overall healthcare, the stats are much lower. I'm keeping my oncologists and all other specialists in Metro Detroit. I'm a 3-time breast cancer patient and very particular about my doctors. What type of interventions can I bring up at grassroots level as a patient advocate to bring attention to a few issues?
Yeah, this is a really good question, especially because of the grassroots aspect. Theoretically, one of my sort of like contributions that I've been trying to make to sort of like the health science world or whatever is really putting a lot of value in local knowledge, that like the way that the reasons why those zip codes that I put on the screen, or those census tracts or whatever, I don't know anything about Alma, sorry. I don't know anything about most of Michigan. Like I know something about my neighborhood, but I think we need to recognize that people are sort of experts in their social world. It takes a certain kind of expertise to sort of be in a place. And so you know why your workplace isn't healthy. You know why it's hard to maybe your home isn't healthy for all sorts of different reasons. And so we need to recognize that people know something about what's going on around them. And so if it's so this question is bringing up transportation, like if that's really like a sticking point that people can't go make their doctor's appointments, they can't afford, they have to buy an individual car instead of having public transportation, which is hugely expensive. Insurance rates are relatively high in Michigan. I think even after the insurance reforms, I know in Metro Detroit they were incredibly high. I think they got a little bit better after the reforms. I'm not sure. That they're some of the highest in the country. And so if these things are making it so that people don't have enough money to buy food because they have to pay incredibly high amounts for transportation, well, maybe that's your issues. And so like we need to recognize that like you sort of know what, if you look around you, you know what your problems are. Maybe you might not know all of them, you might not know how deep they go, but you're going to have some sort of like expertise in that. And so I think we need to respect when like, so like basically grassroots groups can say like, if you've seen that this is a thing for you, then push for it. And you can make some of those connections to things like if you can't get to doctor's appointments, if you can't get your medications on time, if you spend too much of your income on transportation instead of housing, and if housing costs are going up, and it's hard to live, you can't like live under a roof. And so I think starting with like sort of empower, like just reminding people that like that they should be listened to, I think is important, because someone's like, oh, I'm no expert. It's like, well, you are of a kind. Like, you know what's wrong. You can't get around your neighborhood.
I want to take away from the room if there's any here. Okay, because I have a couple more online.
I got a list.
When exploring the map, is there any data about moving and whether the life expectancy is better explained by the childhood zip code or adult?
Yes, and it's disputed in some ways. So there's some literature on adverse childhood experiences, and so some of those tend to stick with you. You can sort of imagine what some of those might be. It could be whether it's a toxic exposure, whether it's abuse of any kind. Those can sort of like have ripple effects across a lifetime. That's why the idea of across the life course comes up repeatedly inside the things I brought up today. It's also I've also written about the idea of a life course. I think it's sort of a key concept. It's a little complicated by what's called the healthy migrant effect. This is something else I've written about. That doesn't just refer to people crossing national boundaries. Also, it can be people migrating from one region to another, like within a single country. And so one sort of complicating factor is that people only tend to move if they're able to move. And so people who migrate tend to be relatively healthy and working age and young. And so we get sort of a misleading perception about what people from a place are like if we only look at the people who left there. And so the people who were too sick to leave didn't leave, and the people who couldn't leave or who didn't want to leave didn't leave. And so it will often be the case that people will be better off if they move. But then we also have to we have to find some way of controlling for the fact that some people won't leave because they are doing more poorly. And that's something that's been like a bit of it's been a sticking point for the literature, where it's really hard to figure out how do we sort of control for that? Like, how do we understand what makes someone leave? And then we can try to understand, like, if people were forced to leave their home, like that's obviously bad, like forced migrants, like the world's full of forced migrants from Ukraine right now. And so it's an empirical question that's like really thorny for sort of unexpected reasons.
Okay.
Sorry, these are kind of wonky answers. Like,
and
it's complicated.
I have one more question in the chat. and I'll see if you can answer this. How do you make sense of poverty and the high cost of cigarettes? Why do poor people smoke? That might be complicated.
Yeah, I mean, it is complicated. I mean, I'm not a smoker, but if one, I know the smokers I do, like one of the reasons they do it is because basically as a response to stress. There's research on this on other substance use as well. Like if it's a way of basically bringing you comfort, then again, you can look at the same problem from different angles. And so one problem is that like people need to stop using this to comfort themselves. And it's been very disputed within the sort of the public health literature about whether it'd be appropriate to do things like raise taxes on cigarettes or raise taxes on non-nutritious foods, so like soda taxes and stuff like that, or sort of pop taxes, things like that. It's very disputed because on one hand, it sort of encourages the behaviors that we think are sort of good in some sort of sense. On the other hand, it's basically a tax on people who are poor, like that's sort of like by design. And so that kind of sucks to tax people who are poor for like obvious reasons. And so the way I try to think of it is if it's a behavior in reaction to adverse experiences. And so if it's a reaction to sort of like having like a bad situation, then the problem to me seems like what their situation is. So like, is it that they have incredibly highly stressful living conditions? It's because they are stressed about their ability to pay rent and things like that. So I'm sort of seeing that as if it's a maladaptive response, is the way some people talk about it, like it's a not graded adaptation to a problem, then the problem is what they're adapting to.
I think we probably have time for one or two more. Go ahead in the room here.
So looking at the map at the very beginning of the
Mhm.
slides,
Yeah.
the southeastern part of the United States has a very obviously
Yeah,
lower life expectancy. And through the whole talk, I mean, economics,
yeah,
there's lots of
yeah. I need to mention.
kinds of people who live there.
I think the death rates from COVID were roughly 4 times higher than in Mississippi compared to Vermont. I think
So, yeah, I was gonna say, there's lots of reasons we talk about why life expectancy is lower. Is there an obvious one why in the southeastern part of the United States that?
It's a lot.
Yeah.
If you want to look up the literature, there's a related literature on what's called the stroke belt. And so like it's like a belt across the United States, like that where there are like high rates of stroke. And so it overlaps a lot with what you saw in the life expectancy thing, like where it's like, well, that's awful. It's that sort of that stew of individual behaviors, but within very, very much contextualized within cultural traditions that go a long way back, within lack of access to healthcare resources. The US has relatively thin social safety nets across the country, but in the southeastern United States, they tend to be even thinner. And so like there's very, very little to catch you if you fall. There's in some of those areas, there's like especially low concentration of healthcare workers, relatively low rates of insurance, like it's a lot of different stuff. And so it's and a lot of concentrated poverty. And so it's like all that mixed together. And it's like, what I don't like is when people will try to make sort of claims like that, people are like every individual person there is like uneducated or making bad decisions and like that. I think that's ridiculous. Like you look at the map, it's like this isn't like a map of people making bad decisions or like they're being unvirtuous or something like that. We have like real population problems. Like we have neglected these people's needs, and that's really tragic.
So we'll do one last question online, and I feel like this maybe could lead to a whole nother hour talk, but we'll
Why
try
not
for
stop
it anyway.
there?
The major implication of your seminar challenges the primary driver of precision and personalized medicine is DNA and one's genes. Today, we know that epigenetics is more important in determining health or disease. Examples: environment, nutrition, diets, psychology, social behavior, culture, habits, economics, politics.
Yeah, I'm not 100% sold on how important epigenetics is. It's there, it exists. Methyl groups attached to DNA, even things that are not coded in your DNA sort of attached to your DNA literally, and they affect you in some ways. I try to stay relatively agnostic on that sort of fast moving area about how much epigenetics per se matters. Again, like it's not that genetics don't matter. but it's just the genetic, so like, let me give an example of like what I think doesn't work, or where I think this is wrong about this. So I'll have colleagues who, I think totally innocently, they'll say like, okay, I'm doing this research on the genetics of stroke. And so like, that's really important. And we need to understand like who's at risk for stroke. Like like these patients who have precision medicine, we need to understand which patients are at risk of stroke. Like, yes, I'm on board. And then in their grant application, they'll say, and also stroke is a huge problem nationally, and it's especially bad for these populations. Like African Americans have relatively high rates, there are other populations that have relatively high rates. And so by implication, my research on the genetics of stroke are going to help do anything about that problem of disparities. No, they just won't. That's been something we've like literally actively tested for to see if there's any kind of association, and it won't. And so like, yes, like let's try to be more precise in how we target stroke drugs and see if there's ways we can predict, like, is this drug going to be the one that's be more effective for you as opposed to this drug? Like, I'm on board, like, cool. But don't assume that kind of research is going to do anything about the zip code disparities, about the stroke belt. Like that's not a map of, that's not a genetic map. And so if you, again, so yes, for stroke drugs, it's not gonna help you with the stroke belt.
Okay. Since we only have one more, let's try to fit it in. Does living in an area that has a lot of factories affect our health overall time? Our health over time? A number of individuals seem to need hip and knee replacements without family histories of these issues.
I don't know about which particular kinds of things that would, like the associations between environmental exposures and hip and knee replacements. I can sort of invent something in my head, but like I just don't know like what the particular association is, but like it is a really important thing that like researchers are going out there doing is actually looking for these clusters of negative impacts. And so looking for clusters of lead poisoning. Obviously that led us to like really important research. Looking for clusters of cancer, especially around, and sort of like knowing to look around factories is like a really common thing to do. Like are there things that people are being exposed to, and is it showing up? It's hard to prove causation. It's really hard to do, especially in the court system because of the way we've set up our court system. But yes, like environmental exposures are hugely impactful, and I wish we had a better way of tracking it. I wish we had a better system for dealing with it. I think suing people is probably not the best way because it's you sue someone after the harm's already been done. I'd rather that we not dump toxic waste instead of suing people afterwards. And so so yeah, it's like it matters. It just depends on which factory and in which place, and there are Superfund sites in this region, or there are in the Lansing area, like the basically like areas designated as needing like really like high intensity remediation to sort of prevent heavy metal exposure, among other things. And so I don't know about hip replacements or anything like that, but like the advice is to sort of like look for the clusters and try to work backwards from there. Although you have to be prepared that sometimes a cluster just means nothing. Okay. Sometimes you just get 3 blue M&Ms in a row.
All of that, let's thank Dr. Valles for his talk this evening. Yeah, and thank you to Alma College, Dr.
Thank you folks online. I really appreciate your patience with the hybrid thing, which is intensely weird every time.
Yeah, and again, thank you to Alma College, Dr. Turk, all you did to help host MyMichigan Health, Saginaw Valley State University, and of course, Michigan State University College of Human Medicine. Have a great evening.
Yes, all those things. Thank you for remembering all of them. I'll stick around and talk. Thank you. Have a good night.